welcome to all those present at the Second International Congress and Third National Symposium of Suicide, Prevention, and Promotion of Mental Health in Children and Adolescents. The students, teachers, mental health promoters, and participants in general, to each of the institutions responsible of organizing this event, and also we are pleased to greet the members of the invited institutions and national, and in this case, international level. One cannot choose wisely for a life unless he dares to listen to himself, his own self at each moment of his life. Abraham Maslow. Next, I'm pleased to introduce Dr. Brandon J. Johnson, Public Advisor of the Abuse and Mental Health Services Administration. He has a Master of Health Science degree from Johns Hopkins School of Public Health, a Bachelor of Science degree in Psychology from Morgan State University. He has been speaker at over 50 public speaking events in the last 5 years. Dr. Johnson has worked as program lead of the Garrett List State Tribal Youth Suicide Prevention Grant Program, Government Project Officer for the Suicide Prevention Resource Center, Agency Lead for the Black Suicide Initiative at SAMHSA, Lead of the Faith Community Task Force for the National Action Alliance for Suicide Prevention. Dr. Johnson has a vast experience in areas of mental health and mental science in general. And it is an honor to receive him in this Congress with the conference Suicide Prevention, Community Healing and Hope for Youth. Dr. Johnson, the floor is yours.
Thank you so much. I appreciate the warm welcome. Greetings from the U.S. Department of Health and Human Services. As was mentioned earlier, I work in the suicide prevention branch within the Substance Abuse Mental Health Services Administration. I've been there for about 5.5 years at this point, and it's truly an honor when I get to do these type of presentations and talk about what's happening, particularly with us and what's happening in the U.S. In terms of suicide prevention, what we're seeing in youth suicide particularly, and also to really talk through where we're going in terms of solutions. Where should we be thinking when it comes to youth suicide prevention? What those things look like, what those initiatives look like, and we really have taken an opportunity to focus on this issue. And I'm excited to share that information with you. And I'm also going to get into some resources. I would love it if it's possible for people that, if you have questions, I would hope you'll be able to put that in the chat and relay them to me. But I'm excited. So let's go ahead and get started. And so the slides that I'll be sharing today will be in Spanish. So I definitely want to thank Carlos, who's been an amazing point of contact for me during this process of getting connected to this presentation, for helping me to translate that in Spanish. I'll be speaking in English, and I believe, if possible, if folks want the ability to get these slides, I think we might be able to do that. I'll just check with my internal people to make sure that's okay. And if it is, I would love to share the slides and the data that I'll be presenting today. And so this is really kind of like how we're going to flow with the information today. I do want to say that these two loving faces that you see on this PowerPoint slide are my two children. And the reason I put them here and put them in this slide specifically is because of the fact of we all, despite the work that we do, the places that we're in, and the things that we've decided to do with our lives, we're part of families, right? We have families that we're connected to. We have young people that we're connected to. And despite the work that we're doing, on behalf of so many other people, we also have our own, families and our own reasons why we're so connected to this work. And these two are part of my why, of the why I do the work that I do. And so really, just, having them there just as a refocusing of, this is, beyond just the work. This is also for the families and the people that we share our lives with. And so looking today at what I'm going to cover, we're going to talk about current trends in suicide among young people, looking particularly at what's happening in the US. We're going to take a couple we're going to take some minutes really looking at specific populations and looking at some trends that we're seeing internally to the US, and kind of talk about how that shaped what we're doing in suicide prevention. And then we're going to really get into, some directions and recommendations that we've developed at SAMHSA, specifically around youth suicide prevention. So like from everything that we've seen, what should we be doing? How can we do this? And I would love to, if it's possible, just have conversation around that, and to really figure out how we can get some of these directions out, so we can help as many young people as possible. From there, I'll talk about our youth suicide prevention grant program and some of the things that we're doing there with that. We've made some changes. I'm going to get into some resources that we have that are publicly available that anyone can access. We would love for you all to get connected to those resources. And then hopefully at the end, we'll have some time for some questions. And so I want to really start and show and go into some of the information and the data that we've seen, particularly in the United States. And so this is coming from our Centers for Disease Control and Prevention. And this data is specifically from what we've seen in trends, but really cultivating with the 2020 data. Our 2021 data is not completely finished and released yet. So that's why it's 2020. And there's quite a delay with, kind of what, how we get our data with information coming from chief medical examiners' offices, coroners' reports, law enforcement reports. It takes a while to cultivate that data. And so next month, all of the 2021 data will be released by the Centers for Disease Control and Prevention here in the US. And I'd be more than happy to share that information and that data with you as soon as we get that. And so where I wanted to start was that recently we've seen overall in 2020, we saw a 3% overall decrease of our suicide rate in the US. And so this is something that we hadn't seen in decades, to be quite honest, that we hadn't seen that significant of a decrease in suicides in our country. Unfortunately, we had been seeing increases year over year over year. And so with everything going on with the COVID-19 pandemic and everything happening, we saw this decrease, a 3% decrease overall. Many individuals expected an increase due to the challenges of COVID-19, the loss that people experienced and things like that. But what we've seen even to historically is that when there's a time of great loss, great impact, what we've seen is that there have been decreases in suicides. And then once that situation has passed, so we look at it with hurricanes, major earthquakes, once we see that has passed, then we start to see an increase, unfortunately, in suicide deaths. And so we saw that last year. But the piece of it that was interesting and that was significant that I wanted to share with you all today is that while we saw the overall rate decrease 3%, we saw increases in our young people between the ages of 10 to 24. So, particularly with our young girls, we saw this increase. But again, this is concerning to us because while we're seeing the overall rate drop, when we looked at the data, we saw that it was middle-aged adults, specifically middle-aged white adults in America. Their decrease brought the overall decrease down. But unfortunately, our young people we're still struggling. And it was something that we caught in the data, and something that, again, when we talk about these directions later in the presentation, this is the data that's driving us to make sure that we're having and meeting the needs of young people. So for our males in the little older bracket, so looking at around 15 to 44, we saw some of those increases, also as well for our males within that age range as well. And so for us, we saw specifically male and female non-Hispanic American Indians and Hispanic persons, multiracial individuals, and African Americans seeing, were highest around 15 to 24. So we're seeing looking at adolescence, looking at those teenage years, particularly what we saw was that different racial ethnic groups within those brackets around 15 to 24 were pretty much struggling. And so it was interesting data because we hadn't seen that level of decrease. And then when we saw it, it was specifically for certain populations. So historically, white Americans drove the rate down, and looking at our racial ethnic groups, essentially it had increased. And so which told us that equity, doing suicide prevention across different racial ethnic groups, making sure it's not one size fits all, and making sure that it was prioritized for our young people was critical in our looking at the data and seeing the data represented in our different groups. So this is the 10 leading causes of death in the U.S. For 2020. This is both sexes, all ages, all races. So kind of really looking at the full picture of deaths in the country. And so as you can see, the second leading cause of death, suicide is the second leading cause of death for those between the ages of 10 to 14. It is the third leading cause of death for young people between the ages of 15 to 24. So this is startling data. And for those of us in the suicide prevention field and have done some work in suicide prevention, what we know and what we're likely to assume is that when you see at the top bar where it mentions unintentional injuries and seeing how large that number is, one could assume or infer that some of those unintentional injuries could have been suicides. We may not have the data to know that. We may not have all of the background information on all of those to say that for certain. But with the data that we do know about unintentional injuries and, overdoses, so substance abuse overdoses, is that some of them could be classified as suicides. And so suicide, generally speaking, is underreported. So we could, those numbers at 581 and 6,062 respectively could actually be higher. Typically, in a normal year, a year that's not competing with the pandemic, suicide is the 10th leading cause of death in the United States. Because of COVID-19 and because of COVID-19's emergence, suicide dropped out of the top 10 leading causes of death. This chart here, didn't mean to do that. My apologies. So this chart here is really taking a look at trends over time. So looking from the year 2000 and going up to 2020, really looking at the trends that we've seen in suicide prevention across the lifespan. And so, as you can see, the lowest bar for suicide deaths is particularly around the 10 to 14 age range. If you look and have and follow how the graph goes, we see that around 2016, we start to see an increase there, specifically with our young people. And if you look right above it at the bar that has ages 15 to 24, you see a more significant increase. So starting at around 2012, 2013, we see a significant increase in suicide deaths among our young people between the ages of 15 to 24. So this is, again, obviously something that is concerning to us, and again, has reinvigorated our work in suicide prevention. Looking at this chart comes from SAMHSA's data in particular. So I do want to mention this data comes from, again, our Centers for Disease Control, which really handles our vital statistics and a lot of our data. This chart that you see here is specifically from SAMHSA. So it's specifically from our National Survey on Drug Use and Health survey that we release each and every year. And so this chart in particular is young persons between the ages of 12 and 17, looking at serious thoughts of suicide, had they made any suicide plans, and actually making suicide attempts, right? So obviously we know that suicide deaths can give you one piece of the puzzle, right? It can give you, unfortunately, the unfortunate situation where a young person decides to end their own life. But also we can get information around suicidal thoughts and suicide plans and suicide attempts. So looking at where those trajectories are. And so this data that we have from SAMHSA really gets into that for our young people. So what we saw in our data, and this is from 2020 as well, is that we had 3 million young people with serious thoughts of suicide, which is way too many, right? That's a difficult number to digest, right? So about 3 million young people had serious thoughts of suicide. Out of those 3 million, 1.3 million of those young people actually made plans to end their own lives, which we know this is a more advanced state of suicide ideation where they're coming up with plans. And they're at relatively significant risk from what we know from our research. And then kind of boiling down from there, we actually saw 629,000 young people attempt suicide. So again, this is a very difficult thing to digest. And so this is looking at 18 or older. So I know we're talking about young people today, but just to give you some thoughts about where that is. So looking at 18 to 25-year-olds, and this is thought or behavior in the past year. So again, this is from 2020. So looking at percent with serious thoughts of suicide, looking at 18 to 25, 11.3, 4% made a suicide plan, and 1.9 attempted suicide. So looking at the data overall, I think to look at as a positive in this is that still for the large number of young people that we see, or young people and young adults that we see having serious thoughts of suicide, only about 1.9% actually attempt suicide. However, the number is way too high, and we want to develop things to make sure that we're helping our young people. Okay, so I wanted to look at this data as well, and this data is major depressive episodes in the last year for those 12 and older. So I wanted to, and these are Hispanic young people in particular. So as I said, we wanted to get into a couple special populations and look where that is. And so for Hispanic young people, you can see the trends for males and females from 2017 to 2020. And so what we're seeing here is that in terms of having major depressive episodes, there was a slight decrease for males from 2019 to 2020 for Hispanic young people between the ages of 12 to 17. We also saw a slight decrease in females, Hispanic young people between the ages of 12 to 17 in 2020. As you can see, there is a difference, a noticeable difference in between males and females of who had a major depressive episode within the past year. Significantly more likely to be female. Could be for a number of issues. Our males might not, be having those conversations, or may not be, connected to support systems. In our country, we see specifically that in communities of color, what we've seen is that they're significantly less likely to receive services for any type of mental health challenges, suicides, thoughts of suicide, etc. Our individuals of color are less likely to access those services. And that's due to a number of reasons, looking at historically where services that meet the cultural and linguistic needs of our communities of color are severely lacking. And it's something that we at SAMHSA have been working to improve. We have a minority fellowship program where we bring in professionals and clinicians of color to really talk about behavioral health challenges in these communities to empower our communities. But there's still a lot of work to be done. You can also see a slight decrease as well in looking at the Hispanic young adults between the ages of 18 to 25. So there was a slight decreases in 2020, but still significantly more likely to be female than male. Taking to look at suicide thoughts, plans, and attempts among Hispanic young adults between the ages of 18 to 25. I'm going to focus on in this chart. And so what we saw was that there were increases with this population, specifically comparing 2010 to 2020. So this is more of a gap in looking at what's happened over time with these trends. And so this is something else that we've had the opportunity to look at. And looking at these increases, significant increases, about a 3% increase of serious thoughts of suicide among these young adults from 2010 to 2020. We've also seen a significant increase in making a plan of suicide, increasing by 1.1%. However, in something that is, a bit of a, good news in a way, is that we haven't seen a significant increase in suicide attempts among Hispanic young adults in this age bracket. So thankfully, there may be, a slight increase, but not significant. And so we want to continue to look at, why that is, what's working, right? What's working specifically with this population? How can we transfer to other populations? Those of you, obviously, who may be interested in the middle-aged population, you can see those there. We've seen significant increases across the board from 2010 to 2020 with that population. Obviously, we're talking about young people today, but again, just something that you all can have and see. Looking at the suicide rates of some of our other races and ethnicities in the United States, we see American Indian, Alaska Natives consistently having a disproportionately high suicide rate versus any other racial ethnic group. This is due to historical traumas. This is due to significant substance abuse issues there as well. Obviously they have dealt with poverty, having been disconnected from their land and having ownership taken of that. And so working with their young people is something that we have as a priority here at SAMHSA, and I'll get into some of our work specifically with that population. We've also seen significant increases, and this is into our continuing with our special population section. We've seen significant increases in African American youth suicide. What we've seen is that there has been the suicide rate of African American young between the ages of about 5 and 12. We've seen that rate in about the last 13 years, incredibly concerning for us. And with white youth, we've seen a twofold decrease in the suicide rate there. So we're looking into that and working on what the challenge is specifically there with that population. And then looking with our African American adolescents, we've seen a significant increase in suicide attempts among African American adolescents between the ages of 13 to 17. And so we're waiting on the 2021 data to see how that trend has increased. But I want to say that that's also something that's troubling that we've seen with those suicide attempts. So to give you the data that I just mentioned, looking at this chart, you can see African American adolescents now having there's that bolded dash line in the middle as you start to see the graph. And so we've seen around 2016 significant increase in self-reported suicide attempts among African American adolescents between the ages of 13 to 17. So again, they have the highest rate now in the country. So we've gone through the data, we looked at special populations, we've seen some of the trends and seeing what's happening across the board. And so now I want to get into talking about some directions, some things that we've seen that has worked in our work, what we want to share with other communities of things that could be beneficial for our young people as we continue to work to reduce suicide thoughts, attempts, and deaths among our young people. So a big piece of what we've started to do and to push around suicide prevention is this idea of continuity of care. So looking at how we can screen young people for suicide risk, to see if they're at risk for suicide, to do an assessment. So if they're found to be at high risk, we do an assessment to assess where their level of risk is in that time, and then ensuring that there's some type of follow-up with them. So if we see you're at high risk for suicide, we're going to connect you to suicide specific care and treatment. We want to know how you're doing. We want to follow up. We've seen in research and in practice that the idea of following up with a young person, following up with their family to see, is there anything else that you need? Were you able to get connected to the services that we provided to mental health providers and clinicians who are trained in suicide specific care, whether it be cognitive behavioral therapy and suicide prevention or DBT. You know, do you have the resources and things that you need? And what we found specifically in our communities of color is also that follow-up piece is making sure that their basic needs are met. So looking at the social determinants of health, do you have access to quality mental health care? Do you have enough food on your table? Like is everyone, is that a stressor that's taken care of? Do you have transportation to mental health providers and things like that? What we've seen is that ensuring that follow-up piece for youth who are at risk for suicide is critical to their care and their outcomes. So this is something that we've incorporated into our grant programs, and I'll talk about that in a minute. But all of that is something that we've been pushing. Ensuring that individuals who are working with youth are trained in suicide, in suicide prevention, that they know how to screen, they know what suicide risk factors are, to identify a young person who may become withdrawn. So naming a couple of risk factors, may not be interested in the things that they used to be interested in. They become isolated. They may become irritable and angry and lash out if they're having thoughts of suicide. Are we training our professionals, our clinicians, our community members, and our families to recognize those signs? And also, are we training providers and clinicians on how to treat individuals at suicide risk specifically? So this is something that we've also, again, have really incorporated into our grant programs. And so we also wanted to ensure that we are doing suicide prevention well among our special populations. And we talked about some of them earlier. So making sure our young people are being targeted specifically in our suicide prevention efforts. Our young people who may be in juvenile justice or jail and prison facilities, like how do we ensure that they are getting suicide prevention within those facilities? Youth who are in the foster care system in the country, making sure, because they are more likely to have experienced trauma if they've been removed from their home, removed from their families, they're more likely to have experienced trauma and traumatic events. That is a risk for suicidal ideation. So how do we make sure we're connecting our young people who may have experienced abuse, neglect, assault? How do we make sure, knowing that they're at higher risk, how do we make sure that they're in a better position to get services, as well as our LGBTQ plus youth, so lesbian, gay, bisexual, transgender, and queer young people? How do we make sure that they have what they need as well? Because they are significantly more likely to attempt suicide, make a plan, and also to die by suicide. So how do we make sure that we're meeting their needs and creating suicide prevention efforts that can reach the things that they're dealing with? Okay. So we have changed our national suicide prevention lifelines number to 988. So we have a 3-digit number now dedicated to our national suicide prevention lifeline network. So we wanted to ensure that, and I'll talk about that in more detail later, but we wanted to make sure that number was able to do chat and texting, so our young people could text. Young people don't oftentimes want to talk on the phone as much as they would be willing to text, and so that's something that we've integrated into that. Care transition, so making sure our young people, as they're transitioning into different levels of care, ensuring that they have everything that they need as they're transitioning. So this goes into the continuity of care piece that I mentioned earlier. So making sure if a young person is found to be suicidal at school, right? And they're connected to a treatment center. How do we ensure that that young person during that during that transition has the things that they need, that their needs are being met? So ensuring the safe transition of young people is critical. I touched on the equity piece in suicide prevention. So even as we talk about young people, whether they be different racial ethnic backgrounds, whether they have different faiths, they may be a part of different faith communities. They may be LGBTQ plus young people. They may have young people who've experienced trauma. They may have young people that are, of different regions. So their, languages are different, or, their customs and things are different. So ensuring that suicide prevention is equitable. So that means that we're not just doing one program to fix all the issues that we see in suicide prevention, right? All the things that I've been talking about in terms of risk factors and social determinants of health. But how do we create suicide prevention activities that specifically speak to the particular risk and protective factors of the young people within those regions, within those areas, within those different makeups of young people? Equity in suicide prevention is something that I have been working on for a long time in my career, wanting to build things for the different types of young people that we have, because young people are different depending on where they are and those things. And so we want to ensure that all of their needs are being met, regardless of the things that they've experienced. Different aspects of their identity, we want to make sure that they have the things that they need, which goes hand in hand with developing culturally specific upstream suicide prevention. So not just thinking about young people when they're in crisis, when a young person is actively suicidal, is thinking about ending their lives, has a plan, and is executing that plan. We want to think more, on the prevention side of that. So how do we help young people not even get there, not even have those thoughts and deal with those things? How do we do that and do that successfully? And so making sure that our suicide prevention efforts are culturally specific can help to do that, because we know our youth of color more than other young people are impacted by those social determinants of health that I mentioned earlier. Is your community safe? Do you have transportation? Do you have quality food options? Do you have quality mental health and suicide prevention services within your community? We know that our young people of color are significantly impacted by that. So how do we create programs that meet those needs, right? It's hard to be good in your mental wellness, be strong when you don't know when you're going to get your next quality meal, or your parent is working 2 and 3 jobs to support the family. It's hard for you to secure housing. So you're going from, a family member's place to another family member's place. It can be hard, right? It can be difficult. And so we want to make sure that we're addressing those things as well. And then funding, right? We want to support as much as we can, because obviously having that financial support really does help our young people, and create programs for them that really meets those needs for the things that I mentioned earlier. I would love at some point, if we're able to, if it's possible, and it's just to have a conversation, or if you all are able to ask questions. I would love to know if there's something that I missed, or something that you see as really important for suicide prevention moving forward. I would love to have that conversation, and you'll have my contact information too. So even if you just want to exchange emails and talk about this, I can talk about this stuff all day. I would love to engage in these type of conversations. So going into this is a program that we have specifically in the United States for suicide prevention. I oversee this program. It is called our Garrett Lee Smith State Tribal Suicide Prevention Grant Program. It is named after a congressperson's son, who died by suicide, who sponsored the legislation. And so it is a 5-year grant program. It's available to our states, tribal organizations, and our territories. Really, the goal is to reduce suicides among youth and young adults between the ages of 10 to 24. And we want people in our program to take a comprehensive approach to suicide prevention. So a lot of the things that we mentioned earlier, like doing as many of those things in as many places as you can with the funding that we provide, is a part of what we do. And so the purpose really is to implement suicide prevention in early intervention strategies, again, in as many places as you can. So in schools, in juvenile justice facilities, treating mental health and mental illness, as well as substance use disorder within any child serving organization. So it can be a community-based organization, a school, a juvenile justice facility, all those type of things. And so our goals are pretty much the same as what I mentioned before. So we have a requirement for all of our grantees to do that continuity care piece. Screen young people, assess their risk for suicide, follow up with them. Training our clinicians, training community workers, training other staff persons to do suicide prevention is another aspect of it that we really want our program to be able to do. Training all of the staff within these places. So training teachers, childcare professionals, community care providers, and training them specifically to meet the diverse linguistic and cultural needs of young people. We added that. We wanted to make sure, as we're seeing these differences that I mentioned in the data before, we have to account for that. We want the services and the things that our young people are encountering to be able to work for them. So we ask our grantees and the people receiving funding, check your data, see who's being impacted. It may be a specific group. We want to make sure, if it is, that you're meeting their needs specifically. Reduce access to lethal means, particularly firearms, for our young people. We have in our country, about 53, I believe, percent of deaths by suicide or by firearm. It's 53 or 57% have been by firearms. So we want to make sure that we're being safe with that. We also want to ensure that we have individuals who have experienced suicidal thoughts, may have made an attempt in the past, to be present in your planning, in your thoughts. We want people with experience around this, personal and lived experience, to be at the table helping the decision makers. We think that that's something that's very critical and important because they have the lived experience. So we should be listening to them and what they're doing. Just to give you all, and then there's a reference to this. If anyone's interested in reading the article, I can send it to you. My email's at the end if you want to email me for that. But specifically, we did an evaluation of our programming within the Garrett Lee Smith State Tribal Suicide Prevention Grant Program. And what we found was that in counties that were implementing these suicide prevention activities that I outlined before, there was a decrease in suicide deaths among young people within those populations. And we saw that with every year, there was continued funding, there was continued decreases. However, what we did see is that once the funding left, the youth suicide rate increased. So it's good for the time that it's there. We have to figure out how to make sure that these activities are sustained and sustainable over time. And so I'm getting towards the end, and I'm going to see if we have time for questions in a bit. So I did want to go through and talk about our makeup at SAMHSA for those who are interested in learning more about what we do and want to access our resources. We would love for you to take advantage of those. So these are our suicide prevention efforts. We have a number of grant programs. I've covered our Garrett Lee Smith grant program today, our state tribal piece. We also have one for college campuses where we give out funding to college campuses to do suicide prevention activities. So it's a little different than the state tribal. It goes specifically to college campuses and works with young people between those ages. We have a Zero Suicide initiative, which is our initiative and grant program specifically for healthcare systems to do suicide prevention. If you're interested in better engaging healthcare systems, if you connect with me, I can get you connected to our Zero Suicide website, or if you Google or look up on any search engine Zero Suicide, you can see the work that we're doing there. We have our national strategy grants. Our Native Connections grants are specifically for American Indian and Alaska Native youth and adults. So specifically doing suicide prevention with that population. And I talked to you about how significantly they have an issue with suicide in our country. 988, which I'll talk about in a minute, community crisis response. And so reaching out to people when they're in crisis to make sure that they have services. We have a COVID-19 specific suicide prevention grant, and then the Suicide Prevention Resource Center I have highlighted because I'm going to cover them in a second, but these are, really our major programs. And so looking under the SBRC, you see the National Action Alliance for Suicide Prevention. This is our public-private partnership to do suicide prevention. So we have our government agencies, so the ones around defense, around our veterans, our Health and Human Services, SAMHSA, our Centers for Disease Control, are our public institutions. And then we have private institutions such as Facebook and some other organizations coming together to really talk about how we can reduce suicides in the country. They have a website. We have free resources there if anyone's interested in looking at those resources. And we have resources that would definitely be applicable outside of the United States. So definitely take a look at that. I'll put their website up in a minute, but it's called theactionalliance.org. So if you go to theactionalliance.org, you'd be able to access their website, and they have a free resource library there as well. And so definitely would recommend that as a resource. So another resource that we have at SAMHSA is the Suicide Prevention Resource Center, which I oversee at SAMHSA, which specifically creates a ton of suicide prevention resources across the board that anyone can access. I would love for you all to access these resources. Take advantage of them. Their website is sprc.org. If you go to their website, their resource library is vast. There are a bunch of resources there around suicide prevention, and they cover everybody. So they cover young people, healthcare, community organizations, faith-based organizations. We cover all of those things. So I definitely encourage you to look at those. I want to talk about a few resources. We have some resources already that are already in Spanish. So these are some of the resources. Our roadmap to behavioral health, our opioid overdose prevention toolkit, our toolkit for LGBTQ plus communities, supporting them, how to talk to a young person about a suicide attempt that may have happened in the family, community conversations around mental health. These resources are already in Spanish if you go in and check those out. Some more reporting on suicide prevention. We have some specifically on what teachers should know around suicide prevention. That's already in Spanish. Our National Institute of Mental Health have also created resources, and we have links to all their Spanish resources as well. Take advantage of them. They're free to download them, check them out. You should be able to access those. And some of our programs are also already in Spanish. our families. One, we have one for veterans and one for emergency rooms. So these programs are already in Spanish as well. So I mentioned we've transitioned our National Suicide Prevention Lifeline into a 3-digit crisis number that just took place last month. And so we are still working on that, but it's a welcome change in our community, so we can get people connected to services with an easy to remember number versus the longer number that we had previously. So for me, this is certainly something that we are dedicated to at SAMHSA. We are here to help and to collaborate. If you want to connect with me to talk further, if you have an idea or something you wanted to know if we had a resource on, any thoughts about anything there, please don't hesitate to reach out to me. I would love to get your email. My email address is there. If you email me, I would love to chat about this. It's so critical for us to take care of our young people, to make sure that they have resources and support to let them know that we care about them. And so, and again, I want to say to you all who are doing this work, who are interested in this work, remember to take care of yourselves as well. This is hard work, right? This is hard work. And so with that, I will go ahead and leave this up if anybody needs my email, and I will go ahead and wrap up and turn it over to Horatio.
Oh, thank you very much, Dr. Johnson. Now, I think we have time for a Q&A section. So, well, the first question will be, well, how do you think the support in America and Latin America regarding suicide?
Sorry, can you get that question to me one more time, Horatio?
Oh, yes. How do you think is the support in America and Latin America regarding suicide? Is it good? Is it enough?
Yeah, so for us, I know that there are some supports and things that are already out there, and I think honestly, I think we need as many supports as possible, specifically in these places. I don't think that we have enough, already for tackling the issue of suicide and suicidal ideation anywhere. I think we're trying to build those things out because the problem is increasing just everywhere. We've been seeing these rates increase. I know the Pan American Health Organization has created some resources as well, and trying to support it and boost up some resources as well. And so there's still a lot of work to do, I think, across the board to meet these needs, because now COVID-19 has happened and has changed even how suicide prevention, it's changed rates, it's changed thoughts around it, and we have to adapt. So I think it's a moving target. So I don't know if we'll ever have enough, but the more we're focused and locked in on trying to adapt as quickly as possible to the trends that we're seeing, I think that we're all being in good shape. And again, if there's any way that you all think we can better partner, please let me know.
Thank you very much for your answer. And the next question will be, how have been the incidents and the participation in the suicide programs? Well, talking about the outcomes, like, have they been successful? Do you think they have been successful?
That's a great question. I think I think they have been successful. I think we have the data that I showed on the evaluation of the suicide deaths among young people decreasing for places that have the program. I think the challenging part is that we don't have enough funding to get everybody funded. If we could fund everywhere and have everybody do it at the same time, right? Like that's best case scenario, but it's not one that's realistic. So there have been some successes. We just have enough to really meet the need. And I think that's the challenging part of it, because we want to try to support as many places as possible, but the work is hard. And some people, and there's still, really everywhere, there's still significant stigma around, and stereotypes around suicide. So some people won't even engage, even if they need the services. There are some parents who will refuse their young people to get connected to the services and programs that we have. And so until we can manage some of those things, it's hard to see widespread impact. So I would say yes and no.
And well, the last question will be, which will be, or what will be the advice for the Mexican mental health professional to apply on the country?
Yeah, so I think specifically there is just, as much as possible, widespread training in suicide prevention, I think is, a critical thing, because there are so many providers that are well trained in substance use disorder treatment and in mental health treatment. But in terms of like suicide specific treatment, that's harder for people to get trained in. And so I would say, find some places that are training and talking about suicide prevention and suicide treatment specifically, advocating for more funding around suicide prevention is also critical. Another piece is engaging community and faith-based organizations in care. There's so many good things that those agencies, those places can do, because there's trust in faith-based organizations. There are people who are in the community where providers can collaborate with and create new programs that kind of meet those community needs that I mentioned earlier, and the suicide specific challenges that I mentioned earlier. And so that would be some of my advice. And again, if there's anything that we can talk to, or any things that you're looking to do, please let me know. I would love to chat to see if there's any other suggestions and things that I could think of.
Well, Doctor, thank you very much. We are really grateful for your participation. This conference, well, we talk about many things. The detection, the programs that we can apply, well, they are paramount for tackling this big problem. So we want to deliver. Oh, give me a sec. Can you see my screen, Doctor?
Yeah, I can see you.
Oh, because the diploma, is it? Can you see the certificate?
No, I can't.
No, oh my God. This is so embarrassing.
No, it's technology. Technology.
Yeah, indeed. Oh, I think that I had it. Oh my God, it's not loading. But I know how to do it. And here it is. Well, Prevent AC, Cuidando y Pensando en tu Salud, La Salle Nezahualcóyotl, and the Faculty of Psychology of the National UNAM present the following diploma to Dr. Brandon J. Johnson for his participation in the Master Conference, Identification and Management of Suicidal suicidal behavior in the Second International Congress and Third National Symposium on Suicide Prevention and Mental Health Promotion on Children and Adolescents. Doctor, it has
Thank you
been
so much.
a pleasure to being with you and learning about all the things that we can apply talking about public health actions.
No, thank you so much. I'm honored. I really, truly appreciate that.
Well, this diploma will be delivered to you in a moment.
Thank you so much. Thank you so much for having me.
It's an honor.